So if there is any burning questions, we will see if we can have time at the end of the session for questions to Nikolai and the other speakers. So I will be touching upon the long-term oncological consequences of the anesthetic care and the surgery-related stress response. Our challenge is that a lot of our patients that we, with cancer that we operate with an R0 resection will, within 2, 3, 4 years, have a recurrence. This is an example for colorectal cancer. If we wrote gastric cancer instead, or pancreatic cancer, we could change the word recurrence with survival. There is a huge impact on survival and recurrence rate after even a R0 resection. So what are the mechanisms leading to this increased risk of recurrence? It is obvious that these patients, then, when we operate them, they still have micrometastatic disease. And the focus for this talk will be to look into what are the perioperative factors that are actually promoting the metastatic process of these micrometastases. So whenever we are going to make a study or read a study with the focus on the perioperative period's effect on either short or long-term outcomes, we have a need to look on the perioperative care quality. Do they do minimally invasive surgery? Do they adhere to ERAS principles? If not, it's actually very difficult to conclude anything on this. So what we did in our institution was to look into, in a framework of optimal minimally invasive surgery and optimal ERAS, to look into how was the gene regulation in relation to surgery. So we measured 25,000 genes preoperatively, day after, 2 days, 3 days, and 10 days after, and looked into how the immune response was in relation to surgery. And what we could see was that there was a massive suppression of the cytotoxic immune response the first couple of days, and also upregulation of factors promoting metastases. In a recent data analysis, this is unpublished, we looked on oxidative stress and inflammatory and immune response in 30 patients with, again, more than 25,000 genes, compared preoperatively to day after and 10 days after. And we looked into repair genes, and out of these 46 differentially expressed genes, 37 of these were downregulated. So the DNA repair mechanisms the days after surgery is downregulated. And if we look on the antigen presentation and the adaptive immunity, which is clearing up the micrometastatic disease, it's suppressed the day after surgery. And when we look on the factors promoting metastases, inflammation, migration, adhesion, and adaptive immune suppression, is increased. So we create a situation where we have the optimal milieu for micrometastatic disease. What about the clinical outcomes? 587 colorectal cancer patients, 96% minimally invasive surgery, 2 days length of stay after colon, and 4 days after rectal. So pretty much state-of-the-art perioperative care. Even that, in that situation, we have 10% reoperated, we have 13% readmitted, we have 14% of our patients with a length of stay more than 14 days, and we have complications of some kind in 25%. So we're good surgeons, we're good perioperative, we have a good perioperative team, but we still have a lot of issues with our patients. So the impact of just having one postoperative complication is tremendous. And there is a dose-response relationship. So when we have one postoperative complication, we will have reduced overall survival, reduced disease-free survival, cancer-specific survival, and there is a dose-response relationship. So the more severe the complication is, the more severe the effect is on cancer-related survival. We made a study where we looked upon the blood cultures of all patients operated for colorectal cancer surgery in Denmark, and said any patient that had one blood sample done within 30 days after surgery due to a doctor of any kind saying, I'm worried about this patient having a bacteremia or any kind of complication, We measured this in 21,000 patients who didn't have any blood cultures compared with 3,000 who did. And the effect was astonishing. There was a reduced or all-cause mortality. The hazard ratio was 1.27. Disease-free survival was affected with a hazard ratio of 1.22. And the risk of recurrence was also increased in those patients that had a blood sample due to bacteremia after surgery. So what we create together with Nikolai and his team is an optimal perfect storm with the various mechanisms all promoting one thing, and that is the growth and the seeding and the progression of these micrometastatic cells in the patient. So what about the anesthesia? This is one of the studies that really put this subject on the field. From Royal Marsden, patients around 2,000, it was 2,607 patients in a propensity matched analysis. All patients with cancer operated, matched perfectly, either inhalational anesthesia or intravenous anesthesia. And they showed that the survival was poorer in those patients that had inhalational anesthesia combined with TIVA. And even when they controlled for comorbidity, so they used ASA class 1 and 2 versus ASA class 3 and 4, the signal was still apparent. Even if they looked on patients with metastases, the signal was still apparent. And this is not just a colorectal or breast cancer. This is also shown in esophageal cancer, showing exactly the same effect on overall survival, with a poorer survival in the group of having inhalational anesthesia. Also recurrence, again, esophageal cancer, poorer oncological outcomes in those with inhalational anesthesia. And finally, also in patients undergoing gastric cancer surgery. This is a recent trial earlier this year with almost 900 patients in each group, both with the matched and the unmatched population, a clear association with inhalational anesthesia. So, finally, how can we, what kind of studies should we be inspired of? And an excellent talk by Nikolai with respect of having a context-mattered, context-based intervention strategy as well. So this is a colorectal liver study. So this is a colorectal metastases from MD Anderson. And they showed in those patients that had a colorectal liver metastasis surgery, if they had an epidural anesthesia, the recurrence-free survival and the overall survival was reduced in the group that had epidural blockade. We have just made another study where the data was present here the last week, where we showed any patient operated for a colorectal cancer receiving non-steroidal anti-inflammatory drugs. So these were all colorectal cancer cases in 6 major hospitals, and we had 1,000 patients having NSAID in one group and the 1,400 not having an NSAID. So this was 2 days of treatment. 2 days of treatment as standard post-operatively, showing effect on recurrence, both in an adjusted model and also in competing risk model, but no effect on disease-free survival or overall survival. So this is my last slide, and this was just to scratch the surface with respect of that there are some clear signals showing that there are some associations with our patients' phenotypes and what we do with the patients with respect of long-term oncological outcomes. So we really need this dialogue with our colleagues from anesthesia to produce the right kind of evidence to change practice. Thank you for your attention.